Okay, so I'm going to start. Well, thank you very much to our ACMI stakeholders meeting. And I think as we discussed and as you're aware, we try to get experts in areas of behavioral health, whether they're providers or mental health court judges or anyone related to the system to come speak. And we are so excited to have Psynergy programs come speak in Arizona because I know and I hope that you guys expand here soon because I love your programming and I think it's a great program. Um, so before we begin, I'll just tell you a little bit about our presenter. So Arturo is the president and CEO of Synergy Programs, located in Morgan Hills, California. He has vast experience in assisting and advocating for individuals and families who are navigating the California County mental health care system. He has tons of experience in supervising intensive case management teams responsible for moving clients to less restricted placement in the Santa Clara County area, managing all the clinical resources, supporting community integration, trying to move people from state institutions to community living, and also has a lot of experience in acute inpatient facilities, locked institutions, individual therapy, couples therapy, family therapy, case management. I want to sign up for all of it. So, and he's worked in so many systems. I've seen firsthand, Chuck and I have seen the facilities. Linda and Arturo were gracious enough to tour us through the facilities. So we're more than thrilled. And on the announcement, you can see all of his experience, how with his education and experience at various places. And then we'll move on to Linda. Let me go to Linda. So Linda Kaufman is Director of Government and Public Affairs, managing admission contracts, supportive housing with ACT and FSP. In the San Francisco Bay Area, she's an experienced public affairs specialist with demonstrated history of working with individuals with SMI and persistent mental illness and community settings, skilled in contract management, coaching, government contracts, policies related to behavioral health and medical practices, strong community and social services professional. I can tell you both that what I've witnessed being with them all day is that they stop at nothing. I've seen Linda have someone drive hours to meet someone that's being discharged kind of inappropriately, meeting them and saying, we are going to go up and do an intake now. So they actually really walk the talk, which was very impressive. And with that, you guys want to add anything before I share your slides?
No, you make me look better than I do. So thank you. That's wonderful. Let me see how I can share screen. Says host disabled. Oh, okay. Okay, there. Wonderful. Thank you so much. Okay. So I will, actually, I think I can see when people raise hands. I'm not sure. Anyways, so Synergy Programs we chose a modified therapeutic community model. It is an evidence-based practice, and the typical length of stay is 19 to 18 months, depending on, it kind of depends on somebody who has a dual diagnosis. Usually 18 to 24 months is, what we're seeing. So that is, there it is. So I think this is a really important screen because this is like one of the key things for us, and that it is an individualized, person-centered, and also built on evidence-based practice. And as we go on, you'll see other evidence-based practices that we use. But I think this is it. I think this is how it should be for everybody, that we're providing the residential housing in a licensed boarding care. And I don't know what the equivalent is there. I think maybe it's called a group home. But it's basically people being supported in the community, out of lock care, and yet also with clinical services next door. So we have our residential program where people eat, sleep, take their medications that are, provided to them. And then next door, we have our own specialty mental health outpatient clinics. And those are all certified by our county partners. So they're Medi-Cal certified clinics, Medi-Cal and Medicare. So we use a dual diagnosis treatment. And if anything, COVID was really hard on us for a lot of different reasons. However, it did allow us an opportunity to really build up our dual recovery model and some new practices that we've been putting in there. Go ahead and change the screen or go forward. I keep on trying to use my mouse and it doesn't work. So again, individualized treatment planning for every individual, evidence-based practice, therapeutic interventions, educational, vocational training and support. So we have our own residential program. Sorry, I saw a chat, but I couldn't catch that. Using the client's community as method treatment. So this is one of the things that Arturo says often, and he still goes out there and assesses clients in the community, is once you come to our program, you are a member of our community. You're not a patient, you're not a client, you're not a resident. You are just like I am, just like he is. We are all members of the community. And we all, we all follow rules. I follow them every single day that I go out driving. So is that a question? I'm just going to look in the chat real quick.
I think so, Linda. What they were saying is that it would be behavioral health residential facility or the equivalent. The one thing I want to say also to that point, one thing that impressed Chuck and I when we were going through multiple facilities is that unlike some facilities, they have their people at the front and their desks. It felt like you're checking in or coming into a fine hotel. Hey, how are you today? What can we do? I see you're doing this. It felt different. There felt a level of respect, and they knew everyone's name, and they knew what they were doing or what was going on. So it felt different to us.
And
just to add, what we like to the message that we like to send is 70% of what we do is hospitality. It's when you treat people with respect, with dignity, when you provide a safe environment, when you make sure that they have they're not hungry, they're not cold, they're not hot, and they feel safe, people are going to respond really well to the treatment. So 70% of what we do is really, hospitality, and again, just making sure that people feel like they're welcome, like they mean something, to the community, to us, and their families, of course. I'm a big family advocate. I think families just suffer just as much as the person who has the illness. I mean, mental illness is just a horrible illness that I wish the system, community, society, the counties, the state, they will see it different, but unfortunately it's not. And so this should be our model, should be the standard of care regardless of what is the financial or social economics of a person. So anyway,
Josh had a
passionate. We're talking about our program, so I'm gonna just let Linda continue, but just wanted to share that with you guys.
So Josh has a question.
Yeah, he was asking, where do you find your residential staff? So I mean, the great thing is the clinical staff, LCSWs, psychiatrists, therapists, LPHAs, nurses, LVNs. So that's the clinical part. On the residential part, I think, personally, I'm going to go to Nordstrom's. We're going to go somewhere where there's hospitality driven services. Prior to 20 years working in community mental health, I was a bank manager for Washington Mutual and Key Bank. And honestly, I've had a more pleasant experience with my clients than in banking. I've had a gun to my head, I've been spit on, I had my tires slashed. Whereas I came with my customer service hospitality model from banking. How can I help you? Never once have I been assaulted, and I worked at a locked facility. I've never been assaulted. I've never been yelled at. So I think, that's what you want to look for. And what Lori was talking about is called our help desk. Really, we wanted to call it a concierge desk, but that sounded a little uncomfortable for some clients. So really it is to help, to greet, to help. And again, the 70%, 30%, something that also is created in Trieste, Italy. So we'd look for maybe not all of that experience that you're going to see at, more of a clinical setting, but in the house part, right now we have 3 new RCFE administrators. So those are assisted living. That means they're coming from a place where, one person pays anywhere from $10,000 to $15,000 a month. Hospitality, you all know those assisted living places, they need to keep their beds filled. How do they do it? Customer service, hospitality, good food, good laundry. So we don't look for somebody who has mental health experience. We look for somebody who has maybe a customer support background, working at a hotel. Anybody working at a hotel, I'm probably going to take.
And also, I can actually train now. I've been in mental health for 30 plus years, and I can actually train almost anything. But the one thing that we will never be able to train is human kindness. The people coming with a heart to really go and help others. I mean, that's one of the things that we also look, for people that have that passionate, that they, that kind heart to make a difference, and those that are devastated by this horrible illness.
So Rachel is asking, so 95% of our clients are Medicaid, Medicare. So here it's Medi-Cal. We have Medi-Cal, Medicare. So that's where I contract with county mental health systems of care. And then I would say probably about 2% of our clients are private pay, self-pay. And then probably about 3% of our clients are Kaiser. I don't know if you have Kaiser out there, but it's a very special contract that we have with them. It's been a great contract, actually. For an insurance company, I was a little suspicious, but it has actually turned out to be wonderful, to be perfectly honest. But most of our clients are from the public system of care. You can go to the next page.
And I don't know if you'll get to it, but you mentioned that you learned a lot in COVID, and now you're able to really implement the dual diagnosis and better. What were the lessons you learned, and how did you translate that into different services, different treatment, different care?
So Mike Weinstein has always been very interested about supporting people with a dual recovery, dual diagnosis. So during COVID, we were allowed to, we weren't going anywhere. That's for sure. Our clients voluntarily stayed on campus for almost 2.5 years. Voluntarily, we're not a locked facility. They always, I find that they rise to the occasion. So during that time, we hired 2 KDAC counselors. So those are counselors who have a specialty in education and addiction. So they've been wonderful. We recently rolled out, it was kind of formed probably in 2022. We use interactive journaling. That is phenomenal. It's an evidence-based practice also, and the work that those clients are doing in their workbooks are just nothing of amazing. I will send you some examples of it. I've been doing that at some of our recent things. I can't share their names, of course, but I can certainly take down what they've written. And then at our Morgan Hill facility, Dawn Scheibel and Karen Flores created a 16-week equine therapy program using DBT, dialectical behavioral therapy, for individuals with a dual diagnosis, secondary diagnosis of substance use disorder. And that has been really successful also. So I think being able to use that time is frankly what we did a lot of.
And again, as a clinician, as a social worker, we're trained to really address almost any issue that our clients have. And in Psynergy programs, when we look at the client, we not just pay attention to the mental health. You also have to pay attention to the substance abuse, because we do know that more than 50% of our clients with mental health issues also have some substance abuse problems. But you also have to look at the medical. I mean, you have to look at the whole person to really help the person, on the recovery. But again, as Linda mentioned on during COVID, I think adding these care counselors in the residential side made a huge difference, and I think it made us a better program, or have more resources for our clients to help them.
So I want to answer Dick's question because it's a good one. It's one that's asked often. Really, we go back to that individualized. It really depends. I feel like an attorney sometimes when I say that, but it depends. So if you are somebody that goes out, gets drugs, comes back and sells them to my clients, then I'm going to put you on a very quick eviction notice to a higher level of care. I'll backtrack a little bit and say that out of 251 clients, probably 235 are LPS conserved. I'm not sure what you call it there, maybe a guardianship.
Guardianship.
A guardianship. So that person, I really will have an active plan to get them out. Somebody who gets high in the community, comes back, sleeps it off. Sometimes we'll send them out for a medical clearance and make sure that they're okay. But it is not automatically that we are going to kick you out of the program. We are going to give you opportunities. So it really depends on what's going on. Bringing drugs back in, that is probably one of our only zero tolerances to jeopardize other people's sobriety. However, if you use and you relapse, then we're going to do a tox screen, and we're going to want to see those scores go down on the tox screens in future ones. I don't know if that answers it enough for you, but yes, we have clients that leave without permission. We ask them to sign in and out. We're not a lock facility, but we have agreements with them. Hope that answered that well enough. You could go to the next. Okay. So these are just, Lori can share these with you also. So these are the different things that you're going to look at: integrated treatment plan, multidisciplinary approach. Again, that clinic working with the residential staff. The clinicians are amazing and they're wonderful. However, at best, or let's just say on average, 20 hours a month is spent with, with our clinical staff, maybe 2 hours with the doctor, 5 or 6 hours with your therapist, the different groups, but 700 hours a month are spent with our residential staff. That's where you're building the trust, eating the good food, and, doing all those wonderful things. So that's where a lot of our focus is also. Accessing for stages of change, that has to do with our substance use program. And we could do a whole nother presentation on that also, if you want, Lori, about specifically our dual recovery program, because I think it's pretty great. Identifying problem lists, using case management care plans. You can go to the next page.
One thing I have to mention when you talk about that, they hired wonderful chefs, and the food is not only healthy, but it's really creative and good. So I mean, that's another thing. They don't just serve crappy food and unhealthy food. They have really healthy food.
I just got an email from a family whose son, unfortunately, has gained almost 18 pounds in the 3 months since he left. And that's common. We see clients coming to us obese, and unfortunately, some of them do gain weight afterwards. Again, these are EBPs, evidence-based practices, recreational therapy. The R indicates residential, and the C is from the clinic. So you'll see CBTP, that was another training that we all just went through. So that's cognitive behavioral therapy for psychosis. That's kind of a new training all of our clinicians have gone through. Mindfulness, these are things practiced in the residence and, at the clinic. Physical, how do you afford this? Like hiring chefs. One of the things I will say, and I'll try and put it in the chat here, or Lori, I'll send it to you, is listening to the podcast that was done last August with Mike Weinstein and myself. He really is the thing. And I think really understanding his vision and how this works, I think it's a great thing to listen to.
And just to add, I mean, that's a very good question. How do you afford, chefs? Again, unfortunately, in mental health systems of care in here in California, as we're more familiar, a lot of times the message that we send our clients is that you're mentally ill person, you don't deserve this, that, and unfortunately, many of these places, I mean, they have really horrible food, and then with so many medications, now we wonder why our clients, bad nutrition, but all these medications that are creating a lot of medical problems. But again, when we look at our business model, I mean, we really, I mean, if food is medicine, if you don't bring the right professionals to cook or prepare the meals for the clients, I mean, it's still going to be very expensive if you just provide kind of this lousy. But if you bring these professionals, they're going to be able to manage, the cost and all of that. Believe it or not, our cost per day per client, I think, is around $10 a day, 3 meals, and and part of that, I guess our what do you call our revenue sources. I mean, this is where counties, pay us a cash to support the clients in the residential. That's how we pay for this great food, this, services in the residential side. And then from the clinical, we do build Medicaid for those services. And then clients do get SSI. So, out of their SSI, that also helps to cover all of this. But at the end of the day, as owner of the program, or we're here to make a difference in people's lives, and our goal is always to make sure that everything that comes in, we put it back into the client care, and by providing great food, a good nutrition diet. I mean, this is the way that it should be done. Not every provider should do the same, and unfortunately, not everybody thinks the way we do. But I highly recommend that, as Linda suggested, to hear that presentation from Mike on the radio.
And Mike also is very supportive of making sure that the places are beautiful. So there's no hand-me-down furniture or mishmash. There's nice art on the walls. The rooms and the colors are nice. Lots of natural daylight. Lots of outdoor areas that are covered with gardens, and so that was something that was unusual.
I did not realize that Sandra Burns was in the house. Lovely, lovely woman from Texas that came out and hung out with us for 2 days. So nice to see you, Sonia, and thank you for putting that in the chat box. I appreciate it. So yeah, smoking cessation, I would say 85% of our clients have a thought disorder, schizophrenia, schizoaffective disorder, bipolar, with psychotic features. And probably about 15% of our clients have a mood disorder, major depression. So as a result, a lot of our clients are on Clozaril, and unfortunately Clozaril has a side effect that can cause incontinence, and that is expensive, so, but we really, that's a small price to pay for laundry, staffing, bowel and bladder plans. If it's a side effect of a medication opposed to an actual medical diagnosis, sometimes Medi-Cal and Medicare will not pay for, depends. So that's expensive. However, what I see, because I manage the admissions department, is there are clients in locked settings for probably longer than they need to be, because no one will accept them because of that incontinent care, or they're insulin dependent diabetics. That's another group of individuals that is very difficult or time consuming and expensive to manage. So, if we can get somebody through our food, which we have done, from insulin dependency down to oral meds, metformin, that's huge, because then all of their placement options open up a lot to someone that will take them if they are just on oral meds. So anyways, you could go to the next one also. Education and vocational training, again, kind of all the things we've been talking about, nutrition, education. Somebody asked about to our chefs. So once somebody moves over to our apartments, I don't know what his title is, Berlin would come and do safety training classes. And then we have rehab staff that will work on the cooking, shopping, cooking, being in a budget. But first they have to go through a safety, can they operate this equipment? We are very diligent and very careful about all of that. So yes, there is an opportunity to cook.
So 2 other questions. One, do you have any clients that not only have serious mental illness, but maybe they're on the spectrum? And if so, how do you deal with that? And the second one after you're done is insulin dependency a housing issue concerning? I know here in Arizona, if someone can't take care of their diabetes, they have
Mhm.
to go to a special home where nurses come in because they don't know how to monitor it and they don't.
Right.
Yeah.
Right. It's the same thing. And you know what's, you know, you hear a lot about cherry picking. I mean, I've worked in admissions for 20 years now, and like everybody's cherry picking. On the other hand, you don't want your loved one going to a facility where they don't know how to manage incontinence, where they don't know how to manage, insulin dependency. So there's more. We're about to open up a new facility for older adults, which is over 59, which by the way, I qualify. And that one will have 24-hour nursing and unlocked older adult programs called an RCFE here in California.
But also that facility also can take people that are under 59, as long as they have some of these
Yes.
medical issues. But
Yep.
otherwise, they will be locked up in the mental health institute.
Right. Now, I will say who I have not accepted is somebody who is a fragile diabetic, that at 3 o'clock in the morning, for absolutely no reason whatsoever, their blood sugars will shoot up to 350. So I'm looking for stability before I'm going to take, that particular individual. So there are limitations with that, but I do see people that need extra medical supports. Going down here, you can go ahead and go to next. Community as a method. This is something that Arturo has talked about as far as people being a member. Arturo, when we first opened the program, I lived at the house behind the facility. Arturo lived at the house behind the facility. Mike Weinstein and I mean, it truly was about as grassroots as you can get. So we lived it, we breathed it, for months and months. I think Mike lived there for, I don't know, 6 years. Arturo, you probably lived there 4 or 5 years. And that's kind of what it took. And I think a lot of our things were born out of what would we want for ourselves? What would we want for our family members?
And you guys still stay there in the
Yeah, we do.
We still have a house there.
It's free housing. Okay, you can go ahead and go to the next one. Do you accept individuals who have criminal record? Yes. So one of the things I'll find it. Maybe I can share it towards the end. So we have clients that have legal restrictions. 2 of our facilities will accept individuals that are registered sex offenders. It's up to us to decide if we feel like they're safe at this point. But they could have that history. Registered arsonist. I don't know how it is in Arizona, but now you are a registered arsonist if you started a fire. So mental health diversion, we will accept clients with mental health diversion. Now care court and AOT are legal restrictions that we will accept. But again, I'm going to look at were you on medications? Were you off medications? Were you on meth or some other, drugs, or were you on or off? So I'm going to make my decision based on things that are you going to be safe with our other residents? And
safe, and just to add, safety is the number one priority for us. We want our clients, the clients that are coming in to be safe. We want their peers to be safe. We want our staff to be safe. We want the community to be safe. So safety is extremely important for us, and we assess for all of that. And as Linda mentioned it, unfortunately, a lot of times people, when they're off of their medications or they're psychotic, they get in trouble with the law. They do things that are, so in some cases, horrible things that they have done, but they were off of medications. They, once they're medicated, I mean, they're a different person. So we look into all those things. How did this happen? If someone is, they were in medications and they knew what they were doing and committed a crime, and it's like no, we will not take that person. But if someone, I mean, we had one time, unfortunately, someone kill another person while they were psychotic. They thought it was the devil, the other person, and they spent time in jail, and then was referred to us, and again assess the situation where the person is and what happened at that time, and we brought him in. graduated successfully, is back with family. So it really depends on what the situation of that person is. But at the end of the day, safety #1 priority, because we don't want anybody to get hurt.
So Lori asked, have you had any violence? I would say one of the best things about us is that we're going to look at those red flags beforehand, see if there's some little triggers coming up. We have had some incidences where clients will just, leave the facility. We're not going to put hands on. We're going to let them leave. If it's somebody who's under conservatorship, we're going to file a missing person report. We have not had a lot of violence. We've had, maybe to avoid violence, they'll punch a hole in the wall. Rare does that happen, but guess who pays for it? It comes out of their personal needs money. But honestly, we are always looking for those red flags and yellow flags and have them go to the hospital before then. And then how you leave is how you come back. It's one of the things we talk about often.
But also, we also, for those high risk clients, because we have also taken high risk ones. As Linda said, we look for those, first signs. Like if they refuse their medications, and we already have agreements with family members, with guardians, public guardians, with county. If this happens, then we need to get them out of our program right away, so they go to a place that is going to be safe for them and others. So those are the precaution steps that we take in order to keep everybody safe.
And, going back, I know 2 people that had started fires in the Marin headlands, and one in Mendocino and one in Marin. And so those individuals, our agreement was they had to be on a long-acting injectable. And if they refused the long-acting injectable, then the county would come pick them up and give them the injection and come back. Or we never got to that point. One woman refused one time for one day, and that was it.
But again, yeah, and just to add, I mean, our clients are as sick as they are. I mean, they also, when they come to a place where they're treated with dignity, with respect, they have nice, safe environment, and the food is great. As they, and pardon my language on this, but they say, I might be crazy, but I'm not stupid. I'm gonna take care of my place that So when even those individuals, they, when they're not doing well, they come in to us and they say, hey, probably need to go to the hospital, help me get over there, because they don't want to lose their placement in when they want to know that they are always welcome to come back. So people even with mental illnesses, the chronic mental illness, they also want what's best for, for themselves as well.
Do you hold
Barbara,
the bed?
Huh?
Do you hold the bed if someone, because for how long?
So we will usually hold it by the contract is 7 days, but I've had it go up to 2.5 months if somebody is at a skilled nursing facility. Personally, I'd rather they do a discharge and then we readmit them. But once you're at a point where you're full, often they didn't want to lose that bed. So they chose to keep it. Also a very difficult to place client. So I understood that. Barbara is asking, is this long-term housing? So people could stay as long as they want to, as long as they need to. Average length of stay is 18 to 24 months, sometimes 9 months. I would say we just did this analysis for a group recently. 22% of our clients have been with us for longer than 5 years. And there are some clients who have been with us for 10, 12, 13 years, because this is the level of care they need. They don't need to be in a lock facility, but they're also not going to be able to be supported at a lower level boarding care. And everybody in between. Some people go home, some people go to supported housing, most go back to a home county boarding care, but there are individuals that have been with us for many, many years.
Thank you.
You're welcome. And we have 55 seconds left. Well, we have 5 minutes left. So environment, trained staff, natural support systems. We do have what we call our statuses. So if somebody comes in on orientation and there's 6 different statuses going to orientation, then they can go out with a peer. And this is all explained to them beforehand too. They go out with a peer, and then they can go out independently with a curfew about 5 o'clock, and then they can go to an independent status themselves, and then they can be a peer support person. And some people don't want to be a peer support. No, that's perfectly fine. But there's a part of a modified therapeutic community called peer pressure. That means I don't have to go tell them what to do. They are there to support themselves. So that's a great model. And peer support, I'm looking at the questions here. What do you do with someone with psychosis who cannot sit through? They do not have to sit through. Maybe it's 3 minutes for one person. Stop. Maybe it's 3 minutes. Maybe it's the therapist going in, meeting them in their room. We have plenty of clients that are in psychosis, thought blocking, talking to themselves, self-talk. So we work
walks with them.
Yeah, go on walks. That's a great one.
Yeah.
It's called ecotherapy now, but it's billable and it's appropriate. You meet them where they're at. Literally, do you have any services to assist families in obtaining? No, I do know a couple of attorneys that have been recommended by case managers that I have, and I can share that with Lori later. But no, it's nothing that we do. We accept LPS conservatees. We work with LPS conservators, but we don't initiate anything. Do you run any secure placements? So the closest thing we have to that, this happened through COVID also. We were getting more clients from acute units opposed to longer term mental health rehabilitation facilities. And that's a type of a locked facility. And our clients were not doing well. You would think that sitting in a hospital for 4 months, they would be just golden. And that was not the case because they didn't have that opportunity of, the groups and, working with a longer term program. So at our program on Folsom Boulevard, it was a 90-bed assisted living facility and it had a memory care unit. So what we did is we turned that into ISS, intensive support services. It is not locked, but the doors are alarmed. It was kind of a natural place for that to happen. So maybe somebody needs a smaller milieu, more support. It's a 1-to-6 client ratio. And then there's a therapist on the floor from 1 o'clock to 10 o'clock, which happens to be the time that everybody wants to leave, by the way. So that really prevented a lot. But no, we do not have a secure placement. That's about as close as we get to it. And our old psychiatrist, Dr. Bonamia, said, we are the locks on the door. The way we talk to clients, the way we intervene, we redirect, we support, we will sit there for an hour and a half and talking to them. So we're kind of that secure placement. It's something that we've thought about, but have not done yet. Mindful walking. Oh, that's a good name. I actually like that. Do you want to go to the next slide? I know we just have a couple more minutes, and I will put these other resources in here for you too. Oh, look at us. If you want a community tour. So Crystal's amazing. Crystal used to run, I want to say it was 140 assisted living communities for Sunrise. She is incredibly competent. She manages all of our administrators. I have all the confidence that she is doing things right. So I love her. My number is on there. I'm always accessible. Rachel, you have a question. Your hand's up, I see now.
Yeah, this one I couldn't really type in the chat. So every program in the country has people that they just cannot help, that are not successful in their program. In fact, I have encountered former Psynergy members, or at least families of loved ones who couldn't do well at Psynergy. So my question is, what kind of individuals have you found, or what situations have you found that you cannot help and that you've had to discharge?
So it's one of the things that we absolutely track. So we have planned discharges, which is very easy to understand. We get a 2-week notice and they're moving back to a lower level care or moving home. And then we have unplanned discharges. What we are trying to analyze right now, and I think the numbers are showing, just because you're coming from an acute unit does not mean you're going to fail our program. And I don't like saying fail. I like saying unsuccessful. I have clients that have been in and out of our program 4, 5, 6, 7 times. And the 7th time, it was like, I would say I cannot think of anybody that we've said no to.
Yeah, but
right.
I think that, the clients that we have not done good at all, actually, our clients that are, and this is more the private pay client or client that is actually living at home, and then from home they're coming into our program. Those
Yes.
ones, for whatever reason, to this
Yep.
day, they
True.
just don't make it in our program, and they, fail. And so those are the ones that I can think of, that are really
Consistently.
yeah. But I mean, sometimes clients come in and they don't they only last sometimes a day, sometimes a week, sometimes a month, 3 months, and then they fail. And then as long as they want to continue coming back, and I mean, we will continue working with them. And we had clients that after the third, seventh time, I finally say, "Hey, this is a good place, and this is where I'm gonna, graduate from the program and go somewhere." But the ones that are coming from home, from out in the community, those ones we have not been successful at all. Almost every single one has failed.
But you said it was private pay. Is it the fact that they're entitled and they haven't hit their bottom, or what combo?
They're at home. They haven't had the benefit of that longer term treatment. They haven't been on their medication.
Stabilization.
Yeah,
Why-
I even recall bringing a couple of clients that actually were open to a county system, and they were at home, and everybody, we all were trying to do a like setting diversion, and again, we took them from home, and they just again, because they probably feel like they don't need the treatment. Why is family forcing them to go to a place that they don't want to go? And usually when that happens, I mean, they're not going to do well. They're not going to respond well to the treatment. And not until they end up in the lock setting, then they're more open to, well, maybe Synergy is much better than, being locked up over here.
What about personality disorders or that type of oppositional defiance? So there's a mental health part that you can use meds. Some people still have behaviors beyond that. What do you do if you have someone that's really reactive?
Personality disorders, and there's a lot of different types of personality disorders. Those ones are challenging. The one thing that I have found out that is really effective with the people with personality disorder, from antisocial to borderline to defiance. The equine program, working with the horses. They whatever they have responded well to that, and they do well. But even people with personality disorders, I mean, we work with them, and at the end of the day, I mean, there's no treatment for changing the personality. But you help them learn skills to, at least for them to manage those inappropriate behavior or reduce the inappropriate behavior. It's impacting the social life of and family or community. The Equine program has been great for those people with personality.
Yeah. Well, we have horses here. So we have horses and we have land.
We are well aware.
Just saying.
Going back to Rachel's question, one of the things we rarely get the opportunity to do is go back and talk to those clients. So a lot of times they're part of the system of care, but they'll be referred to us again. It's like, hey, what happened last time, or what is. But if they're gone, it's unfortunate we don't have an opportunity to say, hey, what could have been different? It's one of the things that we've been trying to do with the county and the conservators also. It's like, could we have done anything differently, or was it just too much? Were there too many people in our program? Did you need something smaller? So yeah, it's something that we talk about every single day.
So any other questions? I mean, I want to be respectful of their time. Like always, you're always willing and welcome to stay on longer, but I want to be respectful of the time. Any other questions for Arturo or Linda?
I'm going to forward some things to you, Lori's, that you can share with everybody, our level of service and kind of how level 1, level 2, and some of those details for you also. And at the end of the presentation, my phone number is on there, my email's on there. I am very available to everybody.
Yeah, I was hoping to see some images of the grounds. I took pictures on my iPhone, but because the
You
grounds
can
are
look at
great.
our website. Our website is wonderful. There's, if you go to the campuses drop down, you can see some of those pictures too.
Okay. Chuck, you have a question?
Yeah. Earlier in the program, when I think Josh was asking, where do you get your people that work for you? And you said you look for them from hospitality area. So do you look for people? Will you accept as workers people from hospitality venues and then train them? Or do you look for them to be dual versed in both hospitality and psychiatric?
I would say both. Someone who's worked at a high-end restaurant who has been trained in customer service and actually does care. Those are the things that we're, you know, it's hard to filter some of them out sometimes. And trust me, we've had people that have started on a Wednesday and by Friday we realize it's not the right fit and hasta luego. Trust me, we've had tons of people. We had a huge staffing crisis during COVID, and you try and give people a shot. Rachel, you had another question?
Yeah, one last question. So, you know, one challenge with the Clozaril patients like you guys have, or members, there can sometimes be like a lot of medical interaction with the provider. You know, you have to adjust the laxative, you have to adjust a dose. And here we've really struggled with, you know, you can only come see your provider once a month. So if your laxative's too high, you're just going to spend all month on the toilet. I mean, like things like that. How do you facilitate more frequent interaction with the doctor or the provider?
Our psychiatrist is right next door. So Dr. Lilly will manage those things until you can go to a primary care physician. So if it is a side effect from the Clozaril, so one of the things he's done that's kind of different is he prescribes a medication that is usually given to children for bedwetting. That seems to have been effective. So he will actually prescribe that, and if they're going to primary care, but we're right next door. He is, you know, he's not going to, you know, do some of your medical meds like insulin dependency. We're going to ask an endocrinologist to work on that. But if there's something urgent, they will deal with that urgent. A lot of things that you're talking about sometimes are over-the-counter prescriptions.
Right.
So he will make recommendations. We have 4 psychiatrists. We're hiring a 5th one right now. And we also have nurses, primary care, not primary care, what do they call? Nurse practitioners that can also prescribe. So yeah, they're medical. There are some of our clients that are on, you know, 15 to 18 different medications, and some of them are side effects to the other medications. So we have to watch them.
And we also have also on our, as a consultant, actually, Dr. Cohen, which I think Lori and
what was the name? Sorry, I didn't hear that.
Dr. Cohen.
Yeah.
That our psychiatrists, if there's some medical issues, we can also, you know, they get on the phone and they talk to him. But they also, our doctors also have good relationship with our clients' primary care doctor. And vice versa. When our clients go and see their primary, they, you know, have concerns or questions about it.
We get all the labs at any PCP order. So
a big, you know, key here is collaboration. You know, again, a client doesn't belong to us. To me, it belongs to us. And we all need to work together to make sure that, you know, that person is cared for.
Well, again, thank you so much.
I'll let you guys
on
with your meeting. Thank you very much for having us. And any of you are welcome to call me anytime.
Thank you, guys.
All right.
Bye-bye.
Thank you.
Good to see you.
Thank you.
Bye.